Chào quý thầy ạ.
Thầy Tiến, em chào anh Toàn.
Chào thầy Tiến, chào thầy Tuấn. Chào thầy Tiến.
Thầy Thịnh vô chưa Toàn?
Dạ thầy Thịnh băng tổ chức chưa? Chào thầy Thịnh, chào thầy.
Tiếp nối chương trình hôm nay tại hội trường 2, phiên 5 tiết niệu 6B English Session sẽ bắt đầu ngay bây giờ và cũng sẽ là phiên cuối cùng của ngày hôm nay. Ban tổ chức xin trân trọng giới thiệu các chủ tọa đoàn gồm tiến sĩ bác sĩ Vũ Hồng Thịnh, tiến sĩ bác sĩ Nguyễn Ngọc Tiến, tiến sĩ bác sĩ Nguyễn Đạo Thuấn và tiến sĩ bác sĩ Đỗ Anh Toàn. Xin mời các thầy bắt đầu phiên làm việc của mình. Xin trân trọng cảm ơn.
Thầy Thịnh khai trương đi thầy Thịnh. Thầy Thịnh ơi.
Hello thầy Thịnh.
Thầy Thịnh đâu? Thầy Lịch lên chưa Toàn?
Dạ thầy Thịnh ta thấy có chào nè mà sao không chưa hiện hình lên.
So we can start now. We speak English. We speak English or speak Vietnamese?
In English, please.
Yeah, we speak English. This is the English session, right?
Yes.
Okay. Welcome to all of you.
Hello teacher.
Alo, có nghe tiếng thầy Thịnh không?
Dạ nghe ạ.
Oh, we hear you.
Rồi, xin cảm ơn.
We hear you. Very good. Sound good. Sound good.
Hear you clearly.
Oh, good afternoon. Good afternoon, the members of FINA who take care the session English.
Yeah. Good afternoon, thầy Thịnh.
Good
Now
afternoon.
we can start now, thầy. We can start now. We can start.
Yes. Now, today we have four topics. Then now the first, I think for the doctor Đỗ Anh Toàn, maybe the doctor Nguyễn Văn Khoa, Đỗ Anh Toàn và doctor Ngô Xuân Thái about the topic, the result of the treatment AML tumor by the selective thrombosis vessels at Bình Dân Hospital. Now, please, Dr. Khoa.
Okay, Dr. Khoa, please.
Good evening, ladies and gentlemen. Thank you so much for meeting with me today. I'm going to present the outcome of selective arterial embolization for ML at Bình Dân Hospital. Would you like to give me some honest opinion? Help me finish my presentation well. Thank you. I divide my presentation into three parts. In the first part, introduction, ML, then reasons and discussion, and finally conclusion. ML are the most common benign renal tumor with prevalence varying between 0.3% and 3%. Renal ML are typically composed of smooth muscle, blood vessel, and adipose tissue. The most dangerous complication is acute bleeding which causes life threatening. Before 1984, management of renal ML were only open surgery, partial or radical nephrectomy. Since the first report was under in 1984, embolization has recently become the new standards for preventive or emergency treatment of AML tumor with minimally invasive selective targets. Almost studies demonstrate embolization is safety and effectiveness. Literature about embolization are mentioned in recipe books and guidelines such as Campbell, Miss and Tanago, EAU. And next, reason and discussion. In this part, I would like to focus on three main points. First, ML associated with TSC, and second, indication for embolization, emergency or prophylaxis, and finally, clinical success. TSC is a genetic disorder. ML usually cause more complication in TSC patient than in non-TSC patient. Our study retrospective study on case had already happened before the study begin. ML patients are not routinely investigated for TSC. This is the reason why rates of ML associated with TSC in Campbell had a high rate when compared with our region. While 80% of ML tumors are polarized, approximately 20% are associated with TSC with a gene mutation. Renal ML associated with TSC grow rapidly. TSC commonly affects the brain, skin, heart, lungs, and kidney. It can cause epilepsy, developmental delays, and autism. TSC association has been informing, empowering, and connecting people affected by TSC to assess the best treatment option, up-to-date information, and support. And this is a patient has ML associated with TSC with the special lesion on the face. With this lesion can help you easily realize the patient maybe has a renal ML associated with TSC. And now with the EAU guideline 20 and 21, everolimus can reduce tumor size in the patient diagnosed with TSC. And in a small phase 2 trial, everolimus were demonstrating polarized ML as well. And with embolization, less everolimus can prevent or slow tumor growth, restore the renal function, and reduce the need for future embolization. Our study had 25 cases with a rate of 44% for leading. In lean study, meta-analysis study, a total of 30 studies comprised 653 patients. A total of 32% of patients were treated by urgent embolization, and the other patients some to release symptoms or receive the embolization prophylaxis. In our study, we consider indication for prophylaxis because recurrent rates in literature we explain for patients to understand advantage and disadvantage. And you can see this is the case with the acute leading on the renal ML on the right side. And this is a challenge case. Bilateral renal ML had performed by the open surgery before. And this is the best treatment. The tumor you can see completely also on the ring. Radical nephrectomy before by renal ML. And now she has recurrent renal ML on the right side. And finally, clinical success. The recurrent was defined as an increase in tumor size of greater than 2 centimeters on follow-up image or recurrent symptoms that require repeat embolization. In our studies, there are 4 cases need the secondary embolization because 1 case for bilateral renal ML, 1 case for left renal ML, the right partial nephrectomy for renal ML, 1 case renal ML associated with TSC, and 1 case with the big renal ML. And there are some factors affect clinical success, selective or non-selective. Embolization, the doctor use vascular loss, absolute ethanol or dilute, and the small or big tumor. You can see this is the case we use the microcatheter can super selective the artery fit tumor After embolization, the tumor completely absorbed on the brain. Conclusion. Embolization is safe and effectively technique for managed renal ML. Renal ML associated with especially bilateral tumor. With embolization techniques can reservation, renal parenchyma, and everolimus. Now, in the drugs can reduce the size of tumor. Thank you.
Okay, thank you very much for your presentation. Now, Dr. Tiến, please, you can introduce this next topic.
Thank you, thầy Thận. I would like to introduce a second topic, second presentation from Dr. Phạm Đức Minh with the subject robotic assisted nephroureterectomy and bladder cup excision without patient repositioning and robot redocking. So please, Dr. Minh.
Good evening. I am Dr. Phạm Đức Minh. I'm lecturer of the Urology Department, University of Medicine and Pharmacy at Ho Chi Minh City, and physician at Trường Hospital as well. First of all, I would like to thank the President and Executive Board of HUNA for organizing this conference and giving me a chance to present our study. Today, my topic is robotic nephroureterectomy and bladder cup excision without patient repositioning and robot redocking at the Trường hospitals. So let's look back about the upper urinary tract urothelial carcinoma. It's specified to 10% of the urinary tract urothelial carcinoma. And the mean of diagnostic imaging, such as the CT scan, and approximately 2/3 of these are invasive disease, and the standard treatment of the condition is radical nephroureterectomy and bladder cup excision. And now, you know, the robotic surgery is comparable with other surgeries in terms of oncologic outcomes. As you know, if you use the robotic system, especially the SI platform, there are two main steps. First, radical nephrectomy. That is require the patient can't go from the top to the bottom. And after that, the bladder cup incision, which is required opposite position of the patient can't from bottom to the top. And the hybrid techniques is applied to use at least as trocar as possible. Additionally, the patient position had to change from a T posture to the land burst posture. And our team performed our own technique that does not require the patient repositioning or reassessment or redocking of robotic arm. The patient were placed at the 70 plank position and 15 candelabra and without table flexion to cut the bladder cuff easily. And this image describes the way we assign the trocar. The first is the camera port at the lateral edge of the rectal muscle, and two finger breadth upper umbilicus, and two robotic port at the same lateral rectal margin. And sometimes we use the third robotic port or not, and two assistant port at the midline between the C4A to the symphysis pubis. And as you see, the left side is similar to the right side. It's very simple. And the patient can adopt at the 30 perpendicular to the patient. So here is the result of our study. We have two cases. One case has a tumor in the renal pelvis, and another case has the distal urethral tumor. So over time is about 120 minutes. Estimated blood loss about 70 milliliter, and there were no complication, and patient was discharged after 5 days. So this is estimate about 2 patients on our study. One is left renal pelvic tumor, and other one is the right distal urethral tumor. As you see, we took the end-flock kidney, ureter, and bladder cuff out. So this slide is talking about the high-freeze pork technique. This study of the pork show the longer over time than our technique. Another study described about the technique of bladder cup incision without the patient repositioning, but they have to move the patient card to a different position, and over time is about 200 minutes. Another study in Jaga showed the technique that does not require the patient repositioning and or robot dedocking. However, they play all the throw card at the same level. This is an obstacle in Asian patients that have a soft flank. So this is a result. For this result, we've moved the 2 assistant. Now it's not to the same level with the robotic talk. We move them to the midline level for avoiding robotic instrument collision. So this is the last slide of my present. To conclude, our initial results show that this technique has ability to reduce operative time with a promising outcome for the patient with the upper urinary tract transitional cell carcinoma. So thank you for your attention.
Hey, Dr. Tiến.
Thank you, Dr. Minh. Thank you, Dr. Minh, for your presentation with the very tough techniques in robotic assistance and nephroureterectomy and bladder cuff with the patient reposition. And this is a very interesting talk about the technique. I think it's a good idea to avoid collision when docking. This is a very big problem when we do robotic surgery. And the next talk, I would like to invite Dr. Hoài Tâm with the topic of laparoscopic bilolithotomy for the large renal stone in horseshoe kidney, a case report and review of literature, the study of Chợ Hospital. Please.
Good evening, ladies and gentlemen. Today, I'm very glad to be here to present a case report of laparoscopic bilolithotomy in a horseshoe kidney. I'm Dr. Hoài Tâm from Urology Department, Chợ Hospital. This is my outline, 5 parts. Horseshoe kidney is the most common congenital renal fusion anomaly with a prevalence of 0.25% in individuals because of urine retention and crystal aggregation resulting from renal structure anomaly. Conculi becomes the most common complication of horseshoe kidney with a reported incidence ranging from 21 to 60%, and 95% of horseshoe kidney are fused at the lower points. Horseshoe kidney is one of complicated case for stone management, especially large stone in this type kidney is quite tough. Management of stone in horseshoe kidney, including open surgery, laparoscopic surgery, PCNL, RIRS, or robotic surgery. The vascular supply to horseshoe kidney is varied from many patterns. According to graphs, there are 6 patterns And the most common parent observed was type 5, 28%, and type 6, 24%. The least common parent was type 4, 4%, and type 3, 3%. The vein is very different. Therefore, parents, in this parent, we can see two IVC here. And in this parent, we can see the IVC is in front of the isthmus of the horseshoe kidney. And horseshoe kidneys are anatomical abnormalities associated with stone formation. Advances in shockwave lithotripsy and endourological surgery have significantly decreased indication for open or laparoscopic stone surgery if percutaneous approaches are not likely to be successfully, and or if multiple endourological approaches have been performed unsuccessfully. Open or laparoscopic surgery may be a valid treatment option. In 1990, first laparoscopic transperitoneal nephrectomy was performed by Graf Kleiman. Since that time, laparoscopic procedures have become an essential and necessary part of urologic practice. In 1994, the first study describing the outcomes of laparoscopic nephrolectomy in patients with Stockholm conculi. In 2004, first-scale use of laparoscopy to manage stone in patients with horseshoe kidney. Currently, improvements in laparoscopic instrumentation and techniques and surgical experience have made laparoscopic surgery a promising alternative for stone treatment in horseshoe kidney. Many reports state that laparoscopic lithotripsy was reported as a promising technique for stone, and in horseshoe kidney, the indication for division of the isthmus of horseshoe kidney are controversial, and if done, it during the concomitant removal of additional defects accompanying horseshoe kidney. According to EAU Guideline 2021, few studies have reported laparoscopic stone removal. These procedures are usually reserved for special cases. A few studies with limited numbers of patients have reported using robotic surgery in the treatment of urinary stone. If percutaneous approaches are not likely to be successful, and or if multiple endourological approaches have been performed unsuccessfully, open or laparoscopic surgery may be a valid treatment option. According to AUA Guideline 2019, open laparoscopic or robotic surgery should not be offered as fertilized therapy to most patients with stones. Exceptions include rare cases of anatomic abnormalities with large or complex stone or those requiring concomitant reconstruction. A small number of case series, prospective trial, and one meta-analysis suggests that laparoscopic or robotic neurolithotomy, myelolithotomy, offers a reasonable alternative to PCNL or URS in these complex patients. The aim of this study was to evaluate the result of transperitoneal laparoscopic myelolithotomy and isthmusectomy of horseshoe kidney. This is a 74-year-old male patient with a diagnosis of left kidney stone, infected hydronephrosis kidney with double J stent and horseshoe kidney. The patient had the symptom of left flank pain, and his vital sign is in normal range. His BMI is 23.8. The patient history in November 2020, he had the symptom of high fever, left lung pain, and dysuria. A diagnosis is infected hydronephrosis, left kidney stone, acute kidney injury in horseshoe kidney, antibiotic, and left side double J stent. The patient recovered after 5 days treatment. His urine analysis showed that leukocyte 500 and his urine culture E. coli with ESBL positive. In this antibiotic gram, the bacteria resist to many groups of antibiotic, including carbapenem, fluoroquinolone, and cephalosporin. In this KUB, we can see that a large radial park stone here and multiple stone. In this CT scan, we can see the isthmus is in front of the aorta and IVC, large pelvic kidney stone and multiple stone in some cases. The patient have high stone burden. So we decided to do laparoscopic surgery. The patient was put in a lithotomy position, remove the reverse double J, play a new double J, and put a polar catheter. The patient is placed in a 45-degree left decubitus Position with slight flexion of the operating table. To extend the ipsilateral flank strongly under general anesthesia. 2 12 ports and 2 5 ports were inserted as shown in this picture, and carbon dioxide were insufflated into his peritoneal cavity to create pneumoperitoneum. Mobilization of the descending colon. The left ureter and the isthmus of partial kidney were identified. Ureter with double chase then was in front of the isthmus. Expose the left renal pelvis is quite tough to detect because of inflammation and adhesion of perirenal fat. The pelvis were open and the stone was removed. Large pieces of stone was placed in the bed and retrieved. A small fragment was sectioned out. Cavity edges were sutured with 405 grain, as shown in this picture. In this picture, we use an endo-GI vascular stapler for the division of the isthmus. As shown in this picture, the isthmus here and after cut to separate parts. A trend was inserted and all ports were closed. The total operative time was 4 hours and estimated blood loss was 20 ml. The pulse of KUB show is on small stone-free. In this patient, mobilization and oral nutrition were included on the first day. The second day, removed trend. The fifth day, fully catheter removed, discharged from the hospital. There were no complications either during or after procedure. No blood transfusion, no fever. The laboratory tests show that no difference between creatinine, hemoglobin, and hematocrit. This technique of hemostasis is a major problem during laparoscopic procedures. Study have reported cases of non-functioning horseshoe kidney heminephrectomy with use of bipolar coagulation, microwave coagulation, harmonics cable, ligature, and endostapler for division of the isthmus. The ideal solution to completely avoid bleeding seems to be the stapler, but this use is possible only in the case of a narrow isthmus. Isthmusectomy may be a useful alternative measure to allow repositioning of the kidney and maintenance of an unobstructed upper urinary tract. In conclusion, laparoscopy is an alternative to open surgery, particularly in the correction of congenital defects of the urinary tract. Although the indication for division of the isthmus or partial kidney are controversial, laparoscopic technique in isthmusectomy is safe for patients as shown by our result. The cosmetic result was much better than open surgery. The recovery time was significantly shorter than open surgery. Thank you for your attention.
Okay, thank you very much, Dr. Lý Hoài Tâm, for your presentation. I would like to give you my congratulations for 2 kinds. The first thing, you speak very good English, so congratulations. And the second time, as a second kind, I would like to congratulate your successful of this difficult surgery. You know, even laparoscopic surgery for big stone, Stackhorst stone, is difficult, not easy to do. But this case, you do the laparoscopic surgery for big stone, large stone, and on the horseshoe kidney. Very good operation, and nice, very nice, and congratulations. So now we pass the last presentation. I would like to introduce Dr. Đinh Lê Quý Văn, right? Đinh Lê Quý Văn. You know, the case report. Management of penile strangulation using dental drill handpiece at Chợ Hospital. So please, Dr. Đinh Lê Quý Văn, please.
Hi, ladies and gentlemen. I'm Dr. Văn from Urology Department at Chợ Hospital. Today, I'm eager to present a special case, penile strangulation and complication of penile rings. At our emergency room, we had a special patient, a 24-year-old male patient, present with strangulated penile. On repeat question of patient, the patient no mental disorders. He was a single less educated worker picket of thick steel hexagon nerves from various from masturbation. On physical examination, even occurs 10 hours ago, no bladder distended, edema of distal penis, low distal sensation. On clinic, we check rigid steel hexagon nerves measures 2.2 centimeter in thick, 4.1 centimeter in diameter. So the big question, how resolve problem from literature, benign strangulation or benign incarceration, rare urology emergencies, synonym benign tonic syndrome. Its reason for patient is to improve sexual art or because of underlying mental disorder or paraphilia. The first author was Gautier, report the first case from 1755. Just about 60 cases reported on epidemiology with the last story by Dr. Darkin at the United States. This disease had a large range from 14 years old to the 54 years. The youngest case just 3 years, and this disease in on geographic region. On a predisposition population that you benign range including the main reason relates erotic reasons, novelty seeker, psychiatric illness, especially schizophrenic patient, on a pediatric population such as endurance. The various objects use benign range divided to group metallic and non-metallic objects. Some image device on pathophysiology, physiology on the two-measured penis divided into two zones, high pressure or low pressure. Ring often placed at the base of penis, refunction as an incomplete tunic with convert low pressure zone to the high pressure zone. It symbol the patient want the penis enlargement and more effective, but it leads to trapped blood and depleted oxygen, and finally lead to penile shell hypoxia and dead tissue such as gangrene. Some image from anatomy to describe blood supply, veno-occlusive mechanism. On clinic, we assess the patient with the temperature on the penis, the pain sensation, pulsation, color or color of penis, and especially the blood ultrasound if it's possible. The type of constrictor, we focus metallic and non-metallic, especially plastic, because plastic object had a high compressor, related high damage on the penis. Benign injury grading classification related to large outer perhaps at 1991, and it revised other outer superstand at 2008. With perhaps they divide five grades. With the final grade, a gangrene necrosis, a complete amputation of the penis, and superstand just symbol this classification with two group. Low grade, it no further intervention because it easily to remove object. High grade injury need to surgical intervention. It relates to the complication of fistula necrosis of penis. On this patient, we had a grade 3 low grade injuries, especially rigid metallic nut, and it's impossible to remove lubricants 10 hours past ago. So how to approach management on patient? The patient do need the urine because about 20% present with acute urinary presentation. This patient had a good urinary stream, no bladder distended, so don't need private urines. So the big question, how to resolve from the literature, they define the many method focus for technique, string technique, aspiration technique, cutting technique, and cycle technique. String technique, use string cord or umbilical tap, slip under the ring, distal part, wrap it tightly, proximal part, pull forcibly, slipping the ring toward the gland. It technique originally to resolve the finger strangulation. some image to the right. Aspiration technique is used multiple puncture wood with gauge 18. It used multiple stop to drain fluid. The doctor make the penis sprinkle to remove object. String technique and aspiration described by picture. Reality on patient, we just use aspiration technique and it failed. Other plan for us, cutting technique, most desirable cutting tool may be unavailable or inadequate at that time. We carefully protect underlying skin by use multiple or cool water irrigation. Some example from our literature how to cut ring with the cutter or angle window rule. Surgical technique, when we failures of the resetting technique, a hard graft 4 or 5 injury but selective individualized because it seemed to be not good outcome. Some image describe novel surgical education of benign contrastic metal. In this case, actually, in emergency, we had a better plan. We followed consultant with a dental college. A diamond drill dental handpiece was utilized to cut the foreign body without injuries to the underlying benign skin. And time to cut just about 45 minutes and almost no blood loss. Result is good. Paraphimosis reduced. The patient discharged home after 36 hours with no adverse effects. Erection heart score was 4 after 1 month follow-up. Compare our patient with other studies at this year's it better outcome. From this case, we had a standard protocol. Unusual tools can achieve one under emergency condition, indicate a dental handpiece. A serious injury which require urgent attention and intervention and to restore blood supply and reasons with lip discomfort. Long-term follow-up with the urologist is necessary. The patient should undergo a psychosexual assessment. Then, thanks for attention.
Thank you very much for your topics. It's very an interesting topic. Now, do you have any questions about our 4 topics?
I see one question from the screen Q&A from Dr. Đăng Khoa. Many thanks for great presentation. This is a question for Dr. Minh Phạm, huh? Dr. Đức Minh Phạm is a question for Dr. Minh. What is the main difference in between left and right robotic nephroureterectomy without changing patient position in terms of technical difficulty? Is there any situation that we have to change the patient position in bladder cup excision step? Thank you so much. This is for Dr. Minh. Dr. Minh, do you understand the question? Dr. Minh.
Yes, Dr. Minh.
Can you see me?
Dr. Minh?
Yeah,
Where are you?
Do you
I'm here.
understand
Can you see me?
question?
Where are you, Dr. Minh?
Yes.
Okay.
Can you see me?
Do you hear me? Do you hear me? The question?
Yeah, I'm hear you clearly.
Okay. And can you answer for Dr. Khoa?
Yeah, thank you. Thank Dr. Khoa for the very interesting questions. And as my presentation, as you see the image of the left side and right side tumor, you can see the left side similar to the right side. And my idea is finding the easiest way to make the order can apply my technique easily. So you can see the right side is mirror with the left side. It's similar to almost. And regarding the difficulty, I think it's similar. between two techniques, right side and left side. Regarding anatomy, the left side nephrectomy is a bit of difficulty from the right side. Yeah, and in my study, and there's no case we have to change the position of the patient or the redocking of the robot or the racing car. Yeah, thank you for your question.
Okay, good. And any question?
Now I have one question for Dr. Tâm. Dr. Tâm. Now, Dr. Tâm, do you hear? Okay, you hear me?
Yes, I can hear you.
Phạm Tâm. I'm sorry, Phạm Đức Minh. Phạm Đức Minh.
Yes, he already, yeah, he already answered the question.
Yeah, okay, yes. Do you have a certain diagnosis before or after surgery?
So sorry, can you repeat the?
Do you have a certain diagnosis? Before certainly diagnosis before or after surgery. In the case of nephroureterectomy.
Yeah, I see your question. In the AU guideline, the means of diagnosis of the UC.
No guideline for you.
Yeah, in my case, I based on the CT scan. There's no case to have to the ureteroscopy for the biopsy. Yeah, because
yes, okay.
CT scan the tumor in the renal pelvis and in ureter tumor is very clear in the CT scan.
Oh, thank you very much.
Thank you, Dr. Minh. According to your modified technique, no change position into section of the radical nephroureterectomy. But I think some comment for your talk. I think it's the big problem. If we are the new surgeon for robotic assisted surgery, because of the docking time for the novice, the new surgeon with the robotic is time consuming. If you have a lot of patients you do with robotic, the time of docking is too short. I think so. When you do with modified technique, I think it's you will get some trouble. It will make your operation time longer. For me, I think I have no experience about that, but I think you can change the position of the patient and redocking, and the docking time I think 10-15 minutes only, and that's some comment for your technique only. And related to the talk of Dr. Đinh Lê Quý Văn, I think it's such a terrible accident. I never met that accident, but I have the idea of whether we need to put the ring by the needle at in the tip of the penis during you cut the ring. You see my question? To avoid the necrosis of the gland of the benign when you remove the ring. You see, we can put the needle, the needle to drain the blood outside when you wait for the ring removal. Can you give some idea about that, Dr. Văn?
Dr. Văn?
Yes, thank you for Dr. Toàn because it's an interesting question. In our case, we just use aspiration for the 1 hour, but the ring is difficult to remove because not had a spinal, so it's difficult to pull our distal bandage.
Any question or comment? Hello, Dr. Thun.
Dr. Thuấn is absent.
Yes. And
It's
in
not
the time I
is not there. Okay, any question for our speaker?
Excuse me, Dr. Toàn. Excuse me. I have some comment for your idea for your comment in my presentation. I tried the many robotic system platform like the SI, XI, and Singapore, and you know the next generation like the XI, you cannot you can change the patient card. You cannot change the patient card for the nephrectomy and the bladder cup excision, but you have to change the patient position. So this change is very time consuming, I see, and I try it, and I think the way to the way to perform the surgery without both of this. And you concerned about the collision outside the collision, and I think about it, and I moved to assistant port to the midline. So the distance from the any port is at least 7 or 8 centimeters. So in my our study, there's no case have the collision.
Thank you for your sharing experience.
Okay. Thank you very much for your more review. Okay.
And
now you
any
have
question?
any question?
Yeah, one question from audience for Dr. Khoa. They say, what is the criteria on imaging study for diagnosis of renal AML, and the role of medical treatment for renal AML at the moment? The question for Dr. Khoa from audience.
Good evening, Dr. Thận, Dr. Tiến, and Dr. Toàn, and all of you. Would you like to repeat your question? Thank you.
What is the
Again.
The question from audience asks you about the criteria for imaging study. You hear me? What is the criteria? What is criteria for imaging diagnosis for AML, renal AML,
Yes.
and the role of medical treatment for this lesion?
Thank you. Thank your question. The question has 2 parts. First, how to accurately diagnose kidney tumor, AML tumor, and the effectiveness of everolimus for kidney tumor. The first, accurate diagnose. When I do embolization for renal AML, we think the accurate diagnose very important because the wrong diagnose very dangerous. And in Campbell and EU 20 and 21, the diagnose renal AML with ultrasound, CT, and MR, because the region of fast in the renal AML. If the suspicion is right by May, we use percutaneous biopsy, and with the CT with standards for diagnose, if more 20 pixels with the under 100, under 20 until you can diagnose this is 100% ML tumor. And the second part of question, the effectiveness of everolimus for ML tumor. In the EU guidelines 20 and 21, they demonstrate everolimus can reduce the size of ML tumor, especially ML associated with TSC, and the rebound of at least 50% of reduction of total volume. Very interesting. That is my answer. Thank you for your question.
Thank you, Dr. Khoa.
Do you have any question?
Yeah. One question to Dr. Tâm. Dr. Tâm, you hear me?
Hello,
Yeah,
Tâm.
I can hear you. Yes.
Okay.
I can hear you.
Okay, one question for you. If the patient has residual stone after removal of stone in the horse kidney, which method would you choose to surgery?
Yes. Good evening, ladies and gentlemen. I'm answer to this question. If the patient have the residual stone, we have the definition of insignificant clinical stone, and if the patient have the symptom, we can perform. We can do a medical treatment for stone, or we can choose software lithotripsy, or we can perform RIRS, including flexible RIRS in the case of the patient have the residual stone, if they cause the symptom for the patient after we perform the surgery. Yes.
Okay, thank you.
Oh, thank
Any
you.
question? You have a still question for our speakers? If not, if you don't have a question, I don't. It's not the question for me, but I would like to share with you. One case at Bình Dân Hospital 30 years before. The lady patient had about 30 years old. She has a bilateral renal AML, and one day she got the bleeding too much, and the surgical team in urology department by Professor Ngô Gia Hí, they removed the kidney because they're bleeding too much. Remove the kidney, and the patient has only one kidney with renal AML, big AML, and then one day she got the bleeding again for the rest kidney, for the unique kidney, the another kidney, and the surgical team, don't have a choice. They remove the kidney to save the life of the patient, and then we did the hemodialysis for her, and then after that, her father, he was working in political or something like this, or diplomatic or something like this, and her father, contact with Philippines urology department in Philippines. And then at the moment, I remember my wife, Dr. Ngô Thành Mai, after my wedding, she went with the patient to Philippines to do the renal transplantation there. And after transplantation, everything's okay, and the patient go back to Vietnam, no problem. And 2 years after, because at the moment, hemodialysis not so good, and the patient died, by one cause. I don't remember the cause, but the patient dies. And by this presentation today, Dr. Khoa presented the selective arterial embolization for the patient for big renal AML, even bilateral renal AML. I'm very interesting. I am very interesting, and congratulations for your team, for young urologists in Bình Dân Hospital now. I like it. I like it because you know, by this presentation, I remember this story because you know, we're not good at the moment. We don't have a new technique, and now you have the embolization, selective embolization for the bleeding or for the big AML. Very good. I like it. Yeah.
Thank you.
Yeah.
Thank you, Doctor.
Honestly,
Thank you, Doctor.
honestly, I like it. Congratulations, toàn ekip to your team, toàn.
Thank you, Dr. Tiến, for your very appreciated comment and some work for him.
Yeah.
Actually, he such an active member of our team, and he can do on of the technique of embolization. Yeah, he helped us. Yeah, too much. Yeah. Thank you.
Very good, very good.
Oh, thank you very much.
Yeah, anh Thịnh, tổng kết anh Thịnh.
Rồi. Now we have finished this our session in English, and in the new year now we are good luck all of you and happy new year. Thank you very much.
Thank you anh. Thank you.
Thank you.
Thank you.
Thank you, Dr. Tiến. Thank you, thầy Thịnh.
Thank you, Dr. Tiến. Cảm ơn thầy Thịnh, cảm ơn thầy Tiến.
Now 2 a.m. in Canada.
Yeah. Thank you.
Okay, I go to sleep.
Thank you for your support. Yeah.
Okay, see you tomorrow.
Thank you. See you tomorrow. Good night. Good night.
And then anh Thịnh, and then we discussed about the good speaker. The good speaker hả Toàn?
Yeah. Dạ thì mà quý thầy chọn thôi. Một là cái thầy với anh Tiến chọn.
Thầy Thịnh.
Chắc là cái trường hợp của nếu không ấy thì Lý Hoài Tâm mới nói rất là tốt.
Okay, good. Em, I agree with you. I agree
nói
with
chung
you.
là mấy bạn này nói tiếng Anh quá tốt luôn mấy bạn.
Rồi.
Quá tốt luôn.
We choose to Doctor
Lý Hoài Tâm thầy ha. Lý Hoài Tâm đó thầy.
Speaker in this session.
Rồi.
Okay.
Lý Hoài Tâm.
Cảm ơn thầy.
Rồi. Chúc mừng các bạn. Nói hay quá. Cảm ơn thầy. Cảm ơn thầy.
See you later.
See you tomorrow.
Bye.
Cảm ơn anh. Cảm ơn Tiến. Nghỉ ngơi rồi mai gặp tiếp. Dạ.
Mai gặp.
Mai gặp PM Mono. Trời ơi. Cái bài anh biết cái bài mình còn mấy năm 55 là còn 3 phút nữa đó. Cái bài Regis Bearing á, em cũng ráng á, mấy ngày nay là cũng đang báo cáo Vuna phẫu thuật nội soi mà ngày mai là có PM Mono, thành ra thôi giao lưu với thầy.
Đúng rồi.
Dạ.
Em phải giao lưu với ông thầy chứ, không cũng tìm em. Không cũng tìm em.
Trời ơi. Dạ. Cảm ơn anh, thôi nghỉ đi chứ trễ quá rồi.
Rồi, thôi anh ngủ nha.
Dạ, bye anh. Dạ.
Rồi,
Cảm ơn anh.
bye.
Dạ.
Ban tổ chức xin trân trọng cảm ơn quý thầy, quý cô chủ tọa và diễn giả của chương trình tại hội nghị ngày hôm nay, đặc biệt là sự ủng hộ tham dự của các quý đại biểu và quý đồng nghiệp trên cả nước. Hẹn gặp lại quý đại biểu vào ngày mai, ngày 8 tháng 1 với các phiên của hội nghị thường niên lần thứ 18, Hunta 18 của Hội Tiết niệu Thận học Thành phố Hồ Chí Minh sẽ bắt đầu vào lúc 8:05 tại hội trường 2. Xin trân trọng cảm ơn và chúc quý đại biểu một ngày an lành.
Chào thầy Thịnh ơi, thầy ngày mai còn mấy phiên nữa thầy ha.
Thưa quý vị đại biểu, nếu quý vị đại biểu muốn xem tổng kết ngày 1, xin mời quý vị đại biểu chuyển sang hội trường 1 để theo dõi. Xin trân trọng cảm ơn.